Hello, and welcome to Homecare Connection, brought to you by the VNA Hospice of the Southwest region. I'm your host, Harry Snyder. In the 73 years our VNA has been around, we have been evolving with medical and technological advances in home care, and our agency is proud to be able to keep up with these times. Today, I'm here to talk to two of the VNA's QI specialists about what they do and why it's important to our patients' care and to patient satisfaction. I'd like to welcome to the show Sharon Davis. Welcome, Sharon.
Thank you.
Sharon is a utilization review specialist, and I'd also like to welcome Allison Moore, who is a certified medical coder. Welcome to the show, Allison.
Thank you, Harry.
So, QI. Now, QI is a sort of, obviously, it's related to the care that we provide.
Correct.
But it's not necessarily something that folks would be familiar with.
Right.
Outside the agency.
Correct. We're in the background.
So what is QI?
It's a quality department. We look at quality measures. We gauge patient performance. We look at data. Is the agency performing the way it should? Are clinicians performing the way they should? And if they are, then their patients are receiving good patient care. They're able to meet their goals. So we, in the background, look at certain information, paperwork that the clinicians fill out when they do an admission, when they do a resumption of care, is when the patient comes out of a hospital after they're already established as a VNA patient.
Okay.
At discharge, at transfer, and at recert. So we look at all of those time points to see what the data is looking like. Is all the disciplines that would be helpful to the patient, have they been ordered? And is the patient progressing toward the goals that they have set?
So, okay, so then I'd like to try to just expand on that a little bit, okay?
Sure.
Because you mentioned a few terms. The admissions and resumptions of care. So what happens, right, is that we have clinicians, whether they're nurses or therapists, when a referral comes to the agency, they go out and they do an initial visit.
Correct.
And that's called an admission visit, right?
An admission visit, correct.
Okay.
If the patient is taking up agreeable to services, we would admit the patient to service.
Okay. And then during that visit, there is a tool that our clinicians use to assess those patients, right?
That's correct. It's called an OASIS.
Okay.
It's a Medicare regulated form.
Okay.
And Allison today became OASIS certified.
Congratulations.
So it's an outcome assessment system information set.
Is that what OASIS stands for?
That's what OASIS stands for. And I think our agency has one of the highest numbers of OASIS certified personnel.
Wow.
Whether they're in-field clinicians or managers or quality personnel.
Okay.
And this is information that the clinicians gather to determine what level of function is the patient at on admission.
Okay.
So what are the needs of the patient?
Yep.
And how do we get them from maybe currently they're ambulating with a walker, but previously to admission they were independent with ambulation. So how do we get them back to where they were?
Okay. So on an admission visit, the role of QI is what?
Well, we will, the clinician goes out and establishes a plan of care, and they'll send a note to quality, whether myself, Jessica Boutin, or the coder, Allison, to say this is ready for you to review.
Okay.
So we go through and we start at the kind of the beginning. Is everything in place? Who's the payer? And if the payer is Medicare, which is our larger payer, when they're answering the OASIS and documenting in their clinical note, are they meeting the Medicare regulations?
Okay.
Does the patient meet the regulations?
Yep.
In order for Medicare to pay, the patient has to have a skill.
Yep.
The patient has to be homebound. So does the patient meet those regulations? And then we will go through and we kind of gather. Allison will start with the code, so maybe I'll have her talk about that.
So I'll go through the referral and read the diagnosis, and I read the clinical note that the clinician puts into the chart.
Okay.
And kind of go based on what their plan of care is, what we're treating, a specific
okay.
diagnosis.
Yep.
So each diagnosis that you have has a code that we would send to an insurance company so that your services would be paid for.
That makes sense.
This is the book I use to look
Wow,
up the codes.
that's
It
a
is
big
very
book.
big. There's a process to it.
Okay.
I'll just show you one. So heart failure, if you have a heart failure as a diagnosis, there's different types of heart failure, or there's like the unspecified. We always try to get the specific type because
sense.
that's what the payer looks for. They want
Sure.
to know exactly what we're treating and how we're taking care of it. So we'll say it's a systolic heart failure. So I would normally start in the front, but I know where it is.
Okay.
She's been doing this
good,
for a while.
yes.
I know a lot of these by heart. So you come to a code and it says, it gives you a I50.2, which says it's systolic heart failure. But beyond that, you need to see if it is unspecified heart failure, if it's acute or chronic, or acute on chronic. And they're all different codes that would be chosen for each different diagnosis.
Okay.
So,
And this is actually really important for the quality and functioning of a home healthcare agency, because in essence, you, and the reason why this is a quality program is because starting at admission, you're looking at what a clinician has observed and determining whether or not it is clear and accurate within the context of how how the OASIS works, right? So there's a
Correct.
piece of this that's OASIS, which is why it's great that both of you have OASIS certification, because it means you understand how the tool is supposed to be used and applied, right?
Correct. That's
And,
correct.
and then also for accuracy of billing, obviously that's really important to know. And then to take that a step further, though, if I understand this correctly, and please correct me if I'm wrong, that in addition to that, part of this quality review is to determine that if this is what's being recommended, then where is the supporting information to support that initial?
Correct.
Is that a fair statement, or?
Right.
Yeah.
So I think what Allison will do, and we have another coder, Pam, and that's their primary function is to code. So what they'll do is what Allison said, we'll look at the referral, determine the primary code based on the clinician's documentation, the order that the clinician has put in. And then it comes to Jessica or I, and we go through all of the other parts and pieces of that admission to make sure that the OASIS is accurate, answered accurately based on the information they're giving us.
Right.
We'll look at the referral as well, not as closely as the coders, and make sure that the code is right. That should be the primary code for this client.
Right.
And then we'll take it all the way through, read all their documentation, look at their orders. Could they, if the patient says a fall risk, did they order physical therapy? If not, we'll put that message out to them. I think physical therapy would be helpful. Or maybe the nutritionist is in need. So we'll put that back out to the clinician to say, these are the suggested changes based on X.
What you would put in.
Right, and then we send it back to them, and if there's any discussion, they'll call and have a discussion with us, or they'll agree, make the changes, and we monitor the patient from there. So we have a baseline of where the patient is on admission,
Right.
and then where do we want to get the patient by discharge.
Yep. And again, so all right, so that's an admission visit.
Correct.
Now you had mentioned a couple of other different types of visits.
Right.
So what would be the next sort of
So the
logical?
next one would be like a transfer.
Okay.
So if the patient experiences an issue at home and has to go back to the hospital,
okay.
we would complete a transfer OASIS. Basically, that's just an OASIS that says on admission you had the patient at X. Where was the patient at transfer?
Okay.
Can we show any improvement? And it really depends on the time frame in between that admission and that transfer.
That makes sense.
Right.
Okay. And so all right. So and then there are, you said something about a resumption.
Right, so now that we've completed the transfer, the patient
Yep.
has landed into the inpatient facility.
Okay.
Now they're ready to come home.
Right.
They've stabilized. Now we would do what we call a resumption of care OASIS. So it's similar to the start of care. It gathers the same information. but it's a shorter time period because once we do an admit, we establish a 60-day episode.
Okay.
So wherever that resumption of care is, it will go to the end of that first
okay.
60-day
Good.
episode.
Yeah.
So the codes may change. We may have been focusing maybe on heart failure. And Allison will take a look at that resumption of care, and she may have to change that code because maybe now the patient went in and had some kind of surgery and has a wound that we're focusing on.
And I think it's important, if I'm, again, I'll please feel free to continue to correct me if I misstep here, but it sounds like, though, that a lot of the paperwork that our staff do with patients is required paperwork by the federal government. This isn't like us going, hey, we need, right? I mean,
this is all Medicare driven. And Medicare, as we say, is the big dog in the fight.
Yep.
And so whatever Medicare does, most of the private insurances are following and requiring the same information.
Okay. And so therefore, throughout the time that a patient is on services with us, as long as there are OASIS elements, there's quality review?
Correct.
Okay. And that quality review is there to ensure that the documents can stand on its own merit. Is that fair?
That's fair. And I think also, I think Allison will agree that it's there to measure patient outcomes. It's measured to patient performance.
Okay.
Medicare has instituted what they call process measures. And they have them, their fall risk or diabetes or pain. These are issues that drive patients back into the hospital, getting a pressure area. So what Medicare is saying is, if we're going to pay you, a home health agency, to keep patients out of the hospital, which is a more expensive undertaking than having them cared for at home, then we want you to monitor these process measures. And we want you to be accountable, and we want you to try to prevent those rehospitalizations.
Okay.
And that's what we look at to say, this is what's an issue with the patient. Say it's pain and falls. How are we addressing it, and how are we making it better so the patient does not have to go back into the hospital?
Okay, so let's talk about that for a minute. So it sounds like that every home health care agency in the country would be subject to that kind of review. Is that a fair statement?
That's correct.
Okay. And how does our agency stack up against?
Very well.
Really?
We are able to print from. We have a support module, I guess I'll call it, from. It's called SHP.
Okay.
It's a strategic healthcare program, and what it does is it looks at the OASIS, and it kind of sweeps them every day at night to gather the data. And Jessica or I will go in and look at it at a daily basis, and it will say, Harry Snyder, improvement in bathing was lower. And so did we pick up on that? Did we find that issue, and what are we doing to address it? So at the end, all that data is kind of gathered nationwide, and it tells us where we are.
Okay.
And we do very well. We are a 4-star rating agency. 5-star is the top. Medicare continues to change the decimal point, I'll say, to reach that 5-star. But we have done very well within our local competition, and then along our statewide competition. I believe this is probably, we are above benchmark in 14 of 18 quality measures. Nationally, we are above benchmark in 14 of 18 quality measures. And we are above our competition locally at 8 of 18 quality measures.
We rock.
So we've done well. I think the clinicians continue their ongoing training. We do a lot of it at staff meetings. If we see a trend, we try to stop the trend and change things. Working with the coders, I think quality we discuss a lot.
We do discuss a lot. We also do continuing education for our certifications.
Oh, okay. And so what does that look like?
So coding, I'm also a certified coder. We have another, so we have 4 in the agency.
Okay.
Allison and Pam are primary to code. That's a once you pass that national exam, it's continuing education credits that you are responsible to do every year. I think it's 22.
22
Oh, really?
26.
Yeah.
Okay.
And then with the Oasis, you go every 3 years. And you actually have to sit for an exam. They don't just do continuing education credits. They make you resit the exam. And that's been, over the years, we've gone, I think, 5 changes to the Oasis. We've gone from an Oasis B, which was the first one, and now we're looking at getting to a D1 in January. So with that, the questions change. That's what we try to re-instruct. Jess and I, Allison will get up to speed. We do a lot of webinars and things like that.
Okay.
Or go to training. And we try to get up to speed so we can share that knowledge with the clinicians out in the field. Now this question has changed to X, and this is the meaning of the question.
And the same, so I know that coding and quality really is linked in a lot of ways. How is coding and quality linked? I mean, is it a clear connection, or is it just generally the same? I mean, how does coding and quality overlap?
I would say it's like a pretty clear connection, because your diagnosis codes are picked around your plan of care that the clinician is addressing, like the problems that you have. So without the codes, you're kind of like, what am I doing in here? You know, there's no.
It supports the skill. The coding will support the skill to be in the house.
That would be important.
You know, teaching is a skill in home care. And so it just supports that education. Also, it'll say if I'm a congestive heart failure patient, do I need telehealth? And we have that opportunity to put them into the telehealth program and have that daily monitoring going on. So it all kind of works together. Quality also, besides the clinicians, which is probably the biggest thing we do every day, we also work with intake to make sure that we're getting the needed and necessary information to start with to serve that patient. We also work with the billing office because we look at the payment side. We look at trying to make sure the agency is successful. The 4-star rating, the process measures, the outcomes. If we have good outcomes and process measures, then the hospitals are going to want to refer to us. Other folks in the community who are looking us up online are going to see that we have good measures. They're going to want to have us serve mom and dad.
And they can do that, right? I mean, the information
go
related to the quality of our agency is public information, is it not?
Public information. You can check anybody who is a home care agency in the
Certified
United States, certified, right? And put in there just the name, the state, and they'll tell you what their level
the zip
of
code,
performance is.
Because,
zip code,
and this is through CMS, right?
That's correct. This is a Medicare
Right. So CMS, the Center for Medicare and Medicaid Services, which is the governmental agency that oversees companies like ours that provide Medicare and Medicaid services. Again, speaking to what you were talking about, monitors quality in a bunch of different ways of companies like ours throughout the entire nation.
That's correct.
And if somebody wanted to see how our agency stacks up against our local competition or in the state or even nationally, and again, you already cited some national, state, and local statistics, that information is available.
Very much available, absolutely.
Yeah, and at a fairly decent amount of level of detail too, right?
Very detailed. Yeah, home care and hospice.
Yeah.
So if someone wanted to check our hospice side
Yeah.
of outcomes, they could do that as well.
And quality is agency-wide, right?
Quality is agency-wide,
Right.
yes,
And-
absolutely. Our hospice program does some of their own quality.
Yeah.
We certainly assist them with a lot. We do,
I do
Allison does
code,
all their
hospice,
coding.
Yeah.
And the other programs, so we have Kids on
Sure.
the Move and
Yeah.
MCH.
Right.
And again, I think it's worth noting, or at least coming back to the fact that our quality staff are certified in the tools, and our coding staff are certified. I mean, these are also standards of quality, are they not? They enable, it ensures consistency. It ensures that we understand what the federal government is expecting of us on a daily basis.
Right. So, and we do, we keep up with the Medicare regulations. We keep up with Medicaid as well,
Yeah.
those and then the private insurances basically, as I stated, really follow Medicare. So if you understand those regulations, you are pretty well set to go.
Yeah.
And I think that's how we kind of cross paths with the rest of the agency is having have that knowledge base of
Yeah.
how do I do this?
Yeah.
And that helps with intake, because intake will say, does this patient need X if they're Medicare? And we can say, yes, they do. Yeah, it's a requirement.
Coding changes every year. Every year there are code updates in October.
Right.
Yeah, and there's a rather large one coming up, is there not?
It's a rather large one coming.
Yes.
Yeah.
Sure, I think we should probably talk about that a little bit, right? So, because it's going to impact how we do what we do.
It is.
It's certainly going to impact you guys.
It is.
Yes.
So there's a new Medicare is changing their payment system
Okay.
for home care, and it's going to be called PDGM, which is a patient-driven grouping module.
Okay.
I have to get that in my head.
Yeah.
Anyways, so basically, coding has always been important to the patient, but more on the clinical side. Coding now will drive payment under this PDGM.
Wow.
So it is very important that our coders
Yeah.
are always up to snuff and having some continuing education. Plus, the agency does give us a very nice coding tool
Yep.
through Decision Health, which helps a great deal. Currently, what happens is if the agency is able to make some money through the therapy threshold, so meaning how many therapy visits were made, drove payment.
Okay.
That will no longer happen because, unfortunately, some agencies in larger states find a way to abuse that, and it causes fraud, and the rest of us pay for it. So that is going away, and it's going to be driven by a diagnosis, which will have to be mandatorily supported by documentation.
Which makes complete sense.
Right. And then the other piece of it is the wound. If the patient has a surgical wound, a pressure ulcer, a stasis ulcer, those type of things will drive payment now. Okay? So process measures will still be looked at. What we call the ADLs and IADLs in the hospice, that's bathing, eating, dressing, grooming. Those issues will also be weighted still in the OASIS. But the payment will also go, currently we're on a 60-day episode, we will go to a 30-day episode. So the part about that will be, that we'll have to look at is the plans of care will need to drive that patient a little bit quicker from where I am now to where I want to be.
Right.
Sure.
So that goal has to be kind of driven. Now, it doesn't mean that we have to discharge that patient after 30 days. We still continue.
Yep.
But what Medicare now has said is that you get most of your money with that first episode, and those later episodes will be less and less and less dollars.
Well, again, and one of the important shifts in the payment model is a more global look at the patient.
Correct.
Throughout the entire healthcare continuum.
Right.
And again, it seems to me that home health care is particularly well situated for that, because we are by far, when looking at hospital or nursing home by far the most cost-effective way to deliver healthcare services.
That's correct.
And if the quality of those services, like ours are, happen to be amongst the best in the country,
That's correct.
then those patients are in pretty good hands.
That's correct.
And I think it's worth also pointing out that our members of our QI team are also licensed, are they not?
Yes,
Meaning licensed clinicians.
that's correct. Jess is a nurse, I am a nurse.
Yeah.
And then we have Allison and Pam, who are everyday first priority
Yep.
coders.
Yep.
And then we have Marcia, who
Yep.
is a non-clinician, but Marcia is our, we'll call her our watchdog, so to speak.
Mm-hmm.
So as we go through this paperwork, we make notes of changes. And Marcia is our follow-up, and she looks to make sure that the clinician has made the changes. If not, she sends them a note, per Sharon or per Jessica. And then she creates our 45s, make sure that everything's good, and gets those off to the physician, because once the physician signs, all the paperwork's in place, then the agency is allowed to bill for services.
Okay. And I mean, again, I think it's important, when we talk about quality, the word quality has a general definition that most people, quality is important.
Right.
For our agency, the work that you all do really is a direct support to the clinical staff, indirect support to the patients, but that ability to have the expertise of the OASIS tool, of the coding, allows for a really informed dialogue to occur between our quality staff and our clinical staff related to what they've observed and what they've recommended for patients.
Right.
And all of that is about working toward what's in the best interest of the patient, what is the best
Absolutely.
outcome for the patients.
Absolutely. What is the patient goal, and
Yeah.
how are we going to meet
Yeah.
that? And absolutely.
And QI and coding really look at that objectively with expertise in the area of quality and coding, and are able to be sort of those partners in quality outcome with our staff. And it makes our staff's awareness of those standards higher, which means more able to have consistency across from
Right.
patient to patient.
That's correct.
And let's face it, as you said, our 4-star rating, which again, unless somebody goes to the CMS website and sees what that means, but that does mean we are amongst the best home healthcare agencies in the entire country.
That's correct.
So I would like to thank you both for being on. This is quality is such important work in any field of healthcare. Obviously, it is something that our agency has always taken very seriously. And quality information is public information. At cms.gov, you can just go up and plug in information and see what you'd like to see about any home healthcare agency in the country. But that is all the time that we have for now. So I would like to say thank you for joining us. Thank you, for sharing your knowledge with our viewing public. If you'd like more information about any of the services that the VNA provides, you can call us toll-free at 800-244-0568, or visit us online at www.vermontvisitingnurses.org. I'm Harry Snyder for Homecare Connection, and we'll see you next time.